Thank you very much for having me. My name is Dr. Ray Duncan and I would like to talk to you today about the role of long COVID phenotyping to help successfully guide clinical treatment strategies. Long COVID, as we're aware, is a complex multi-system disorder with around 250 symptoms which can occur in clusters. In general, it's an umbrella term for multiple symptoms and syndromes caused by the triggering of several pathophysiological host response pathways. And because of the complexity of this disorder, it seems unlikely that we're going to find a single elusive diagnostic biomarker for long COVID as a single entity. And it's also unlikely that a single magic bullet treatment is going to be effective. However, if we can break long COVID down into bite-sized chunks by dividing the symptom clusters and the underlying pathophysiology into phenotypes, which is the medical term for subgroups, we can then start treating the different subgroups in isolation. And what we've seen from our understanding of the research so far, and this is again reflected in what we're seeing in our clinics, is that there appears to be several potential drivers of long COVID, including potentially viral persistence in a certain proportion of individuals, chronic inflammation, autoimmunity, and gut dysbiosis may also be playing a role. But we're seeing several pathophysiological disease patterns within the spectrum of long COVID, and I've just listed some of them here. I want to highlight the importance of ascertaining these phenotypes when it comes to treating a patient, and I'm going to do that by using the case of patient X. Now, patient X is one of the patients that was part of our recently pre-printed UK microclot study that was led by my colleague Dr. Caroline Dalton from Sheffield Hallam University. Patient X was a 45-year-old fit and healthy healthcare worker. Like many of her colleagues working in the NHS in the UK, she was re-rolled to help go and work on an acute COVID ward at the beginning of the pandemic. This was around the time, for those of you who are not from the UK, where our public health teams decided to downgrade our PPE, and this individual, along with many of the NHS teams, were not given any respiratory protective equipment. Perhaps unsurprisingly, caught acute COVID fairly quickly and never recovered. This individual did manage to return to work, but struggled on and off with symptoms, exhaustion, headaches, fatigue, PESI, and a myriad of other symptoms. Was referred to a long COVID clinic, but they were in their infancy at that stage and prioritising hospitalised patients, so ended up waiting almost a year to be seen. During this time, there were some slow improvements in between spells of sickness, but a rather large relapse in February 2021 resulted in a significant period of work. Attempt to return to work in March, found they weren't coping again and had asked for an amended job role, but there was a delay in the occupational health referral, and due to being short-staffed, had attempted to continue to work until the point they actually had a huge post-exertional symptom exacerbation relapse, collapsed at work, and ended up being signed off on long-term sickness absence. At this point, they were largely bedridden for many hours of the day. They were seen in a long COVID clinic in 2021, an NHS clinic. Routine blood tests were normal, as is often the case, and they were advised to rest and pace quite sensibly and referred to psychology and neurology. Unfortunately, the neurology referral was rejected and a letter was sent back to the referring doctor and the patient, suggesting that their symptoms were likely deconditioning, with advice to the patient to buy an exercise bike and to do 10 to 15 minutes of high impact cardio exercise per day. This was a patient who was largely bedridden at this stage. They obviously didn't and couldn't do that, and despite taking the advice of the long COVID team and resting and pacing, they had a further deterioration in their symptoms, and by the start of November 2021 They were bedridden in a darkened room with light sensitivity, requiring morphine for the pain. Now, it was around about November 2021 that several of our doctors and scientists from our Team Clots group got involved in this patient's care. And what happened next? So after they've been sick now for over a year and a half, they were reassessed using phenotyping. And the history was suggestive very clearly of new onset food intolerances and alcohol intolerances and dermatographia, and so they were given a clinical diagnosis of a mast cell issue. They were then seen by a COVID-aware cardiologist and had an MRI to exclude an active myocarditis, underwent ambulatory ECG monitoring and an active stand test, and were diagnosed with postural orthostatic tachycardia syndrome, orthostatic intolerance and inappropriate sinus tachycardia. So they had the long COVID dysautonomia phenotype. They met NICE guidelines for diagnostic criteria for ME/CSF, and it was also suspected that they most likely had the neuroinflammation phenotype due to their severe crushing headaches, cognitive dysfunction and light sensitivity. Over the course of a few months after treatment for the first two phenotypes was started, they were then one of the first patients to be enrolled in our UK microclot study, and upon further assessment it was very clear that they also had a very significant vascular coagulation phenotype. So with regards to the mast cell and histamine issues, they were trialled on fexofenadine and famotidine, which are H1 and H2 blockers. Unfortunately, the patient was unable to tolerate famotidine and so was switched over to rapatidine, which is an H1 blocker that has additional platelet activating factor antagonist activity. In this particular patient's case, that was very helpful, and they had some mild improvement. With regards to the dysautonomia phenotype, they were started on non-pharmacological interventions with fluid, salt and compression hosiery, and given ivabradine 2.5 milligrams BD, again with some mild improvement of their POTS phenotype and heart rate. In February 2022, they were enrolled into the UK microclot study. And as we can very clearly see here, they had significant microclotting compared to a normal control that has almost hardly any. It was also very apparent under immunofluorescent microscopy that there was several shards of endothelium floating around in their bloodstream, suggesting endothelial damage. Their pro-inflammatory cytokine levels were very high, and just to give you an idea of this, they were compared to a recently published study at the time of enrolment, and their interleukin 6 and interleukin 8 levels were higher than the highest levels seen in this previously published study. The patient themselves then went and sought some independent validation from a specialist clinic and had further tests done, including tests of platelet studies, and was shown to have evidence of platelet hyperactivation. In the UK study, patient-reported outcomes were recorded. Now, at the time the study was set up, there wasn't any long COVID specific questionnaires that had been validated, so the FACIT fatigue score, PROMIS and EUROQOL scores were used. We obviously do now have long COVID specific questionnaires. Because they had evidence of significant dysautonomia, they also underwent transcranial Doppler examination of the cerebral blood flow in their brain, and they had this performed lying down and standing up after a 10-minute active stand, and their blood flow in their brain was compared to that of an age, gender and BMI matched COVID naive control subject, and it was found that our patients' cerebral blood flow dropped by 18% when they stood up, with associated symptoms of orthostatic intolerance, in comparison to the control subject who had no significant change in cerebral blood flow to the brain on stand. But perhaps most markedly, the most marked abnormality we saw was in their fibrin amyloid microclotting profile. And this slide has been taken from our recently pre-printed UK microclot study that's been led by my colleague Caroline Dalton. And What the study very briefly showed was that all patients studied who'd been infected with SARS-CoV-2 had some degree of microclotting. This was highest after recent infection, and in those individuals that recovered, generally speaking, their microclot scores dropped off as the body began to break them down to the low levels that we see here. With the long COVID subjects, however, their microclot scores in general stayed much higher, although there is a subgroup down here that had similar microclot counts in comparison to the recovered controls, even though they still had significant fatigue, suggesting that perhaps another one of the pathophysiological pathways was playing a more important role in these individuals here. So what we believe is that diagnosing somebody with microclots, i.e. present or absent now, is not enough, and we need to actually be able to quantify the burden. And the Sheffield Hallam team have spent the last 2 years developing and validating a technique to do that, which is now being considered for publication. And using that technique, what was found was that our patient X had the worst microclotting seen in the whole study. Due to the severity of their symptoms and also due to the severity of their biomarkers, they sought further consultation in a specialist clinic, and with informed consent they underwent clinician-initiated treatment with triple therapy, which is a combination of antiplatelets and a direct oral anticoagulant. They were also started on a statin for its endothelial stabilising and anti-inflammatory properties, and a proton pump inhibitor for gastric protection to stop irritation of the stomach lining from the antiplatelet medication. And they were commenced on that for 4 months. They were followed up very closely clinically, and they were also followed up longitudinally in the UK microclots study. At 4 months, the clinician decision was to reduce the dose of the anticoagulation therapy because there was a concern that over a longer period of time there may be a risk of bleeding. So that was reduced. The patient had no side effects from the therapy, it should be mentioned, no bleeding, significant bleeding issues. And after the 4 months, they were further reassessed, and they had optimization of their POTS control with the addition of fludrocortisone and pyridostigmine, and optimization of their mast cell with the addition of ketotifen. And here we have the results from their follow-up in the UK microclot study. So the first review was pre-treatment. So at this stage, the patient had already been started on ripatidine, ivabradine, salt and fluid. They'd been on that for a couple of months, but this was before they started the anticoagulant therapy. Second review was at 4 months of treatment with the anticoagulant regime, plus the ripatidine and the ivabradine. And the third follow-up was at 12 months follow-up with all of the medications previously listed. And what we can see clearly is that their microclot count is very high, and that over the course of treatment it has dropped off to levels that are now within the same ballpark figure as the recovered controls. Their pro-inflammatory cytokines were beginning to drop. We haven't got the third follow-up results yet. Their POTS control and their inappropriate sinus tachycardia control started to improve. The magnitude of drop in the cerebral blood flow to the brain on standing also improved. Their fatigue improved, and their other symptoms and quality of life scores also improved. And looking at this in graphical form, what we can see is that the severity of microclotting dropped off really quite quickly within the first 4 months of treatment, and this was also associated with a rapid improvement in fatigue score and other symptom scores and quality of life scores. With regards to their dysautonomia, with regards to their POTS and their IST, this is when the ivabradine was started, this is when the triple therapy was started, and we can see there was some improvement with the ivabradine, salt and fluid in both before we started the others. We deliberately decided not to add any more POTS medications to the patient's regime while they were on the triple therapy, because we wanted to see whether their triple therapy would actually improve their POTS control as well, and it suggested that there was an improvement, and we also saw that on the lying and standing cerebral blood flow measurements. What we can see here when we plot the fatigue over the microclot severity is as the microclots began to break down and dissolve, the fatigue got better. But probably the most marked finding was that this patient, who by the time they were enrolled in the UK microclot study and started on triple therapy, had been sick for 2 years, had been bedridden and off work sick for a year. By 4 months of treatment, they were well enough that they were able to start back on a very slow graded return to work with reasonable workplace adjustments, and they have managed to maintain and improve on that over time, and by the end of the 12-month follow-up they were back at work 34 to 35 hours a week. So in conclusion, although this individual is not cured and still has to be careful and rest and pace, they have significantly improved from being severely impaired and bedridden to economically active and having a reasonable quality of life. We hope we have shown that if you break long COVID down into differing phenotypes and treat each one separately, that you can actually improve patient outcomes. And we believe there is an urgent need for combined drug therapy trials. We also think that given the spread of microclot burden seen within our UK microclot study, is that it's not enough now just to say if somebody has microclots or doesn't. We need to be able to quantify them. And it may be that this new method for microclot quantification could be a very useful biomarker in those with the vascular coagulation phenotype that can be used to try and help identify patients that may benefit from anticoagulant and antiplatelet therapy on an individualised basis, but this needs to be looked at in the larger confines of a clinical research study. Careful phenotyping can help identify different subtypes of long COVID and be used to guide the development of treatment trials, but also the development of certain treatments. And it is likely that one size isn't going to fit all. So why is all of this important? Well, it's important because the pandemic's not over. COVID's not gone anywhere. And actually, long COVID is a growing problem. And we know now that the highest prevalence we're seeing at the moment, 5 years in, for long COVID is in the economically active age group. We also know that we're seeing the fact that long COVID risk cumulatively rises with repeated SARS-CoV-2 infections. And our recently released ONS winter survey data has shown that in the UK there has been a significant rise in the figures of long COVID from March last year. The data release was just looking at England and Scotland this year, showing that there's 2 million people affected. When we extrapolate that across the whole of the UK to make it comparable with last year's UK-wide data, that's around 2.2 million people affected, which is a rise of 300,000 from last year. We've seen a significant rise in chronic long-term sickness absence from our UK workforce, and unfortunately what our ONS winter survey data just recently released has shown is that the levels of long COVID in children in the United Kingdom has doubled since last year. Recent economic modelling data has shown us that if we continue on the same trajectory without trying to reduce reinfection risks, that the economic modelling suggests long COVID will be costing the UK billions of pounds per annum and over 130,000 job losses per annum by 2030. So this is a huge problem. Unfortunately, despite this huge ongoing and rising issue, the funding for long COVID clinical care in England has been decentralised this year. We still don't have physician-led specialist long COVID clinics to any great degree in Wales or Scotland. And as it stands at the moment, there is no government ring-fenced funding for any long COVID drug therapeutic trials in the UK going forward from here. So what is the solution? Well, before we can solve a problem, we have to acknowledge that it exists, and we have to acknowledge the scale of the problem and start looking at ways around it. So one of the first things is to invest in public health protections to reduce the reinfection risk, to stop more people developing long COVID. But the others is investment in treatment trials tailored to phenotypes and investment in clinical payer pathways. And we hope that this simple case illustration has demonstrated that although long COVID is a complex condition, although there can be in some quarters a tendency to say, oh, long COVID, there's no cure, we can't do anything, actually there's a lot that can be done. And if you have an in-depth understanding of the pathophysiology with careful phenotyping, you can tailor treatments that can significantly improve long COVID functional capacity and quality of life in those suffering from this illness. And based on that, we think there is some very urgently needed combined therapeutic drug trials required to look at this at a much larger scale. What we believe, and when I say we, I'm talking about myself and some of my Team Clots colleagues from the United Kingdom, is that one of the ways that we could solve some of the issues of long COVID with the research and the clinical care is to develop a specialist clinic that is hybrid and integrates long COVID clinical research into the clinical care pathway with the appropriate ethics approvals, and it would be run by specialist physicians with an interest and an understanding of the disease and supported by our biomedical scientists. And doing it this way, we feel it could significantly improve the outcomes in long COVID and reduce the cost to the economy. We believe that we do actually have the understanding, the experience and the skill set now to do this in the UK, but what we don't have is the funding to get this set up and running. Now, some people may argue that we can't afford to do this. I would argue very strongly that the science is telling us, that the medicine is telling us, that the economics are telling us, and that humanitarians are telling us that we cannot afford not to. Thank you very much for having me talk. I would just like to finish by saying thank you to my colleagues, both from the UK Microclots research team and from the Long COVID Research Collaboration, and to all the doctors that were involved in this patient's care. But a special thanks has to go to Associate Professor Caroline Dalton, who headed up and ran the Microclots trial out of Sheffield Hallam University. Thank you.